Hello and welcome to Thursday's Zoom. We're going to be doing chapter 16 and we're going to be covering some coding questions at the end of the little bitty lecture that we're doing. And those coding questions are going to be on your exam. Just one moment. Let me answer a message here from Shalandra that's on the call. Hi, Melinda. We were just getting started. I just hit record. Glad you're able to be with us. Shalandra says that she can't hear me, but whenever she got off of mute, I could hear her. So I'm not sure what's going on there. But we're going to do a little lecture on chapter 16. It's not very long at all. And then we're going to go straight into some coding. And every coding scenario that we have on our lecture or in our little Zoom that we're doing today will be on your exam for chapter 16. And chapter 16 is only coding. There's nothing else on there. Okay, so let me share my screen. All right, we're doing chapter 16, the respiratory system, and we're going to get through the not so fun part so we can get to the part we love, which is the coding. So the one thing that I wanted to point out is I want to remind you that in your books, in your textbooks, and in your CPT manual, there are lots of anatomy diagrams. Please pay close attention to those. And if you need to refer to those to get a better understanding of the anatomy or, to find out where something is, please remember those resources. The respiratory system subsection is arranged by the anatomic site, which would be the nose, accessory sinus, larynx, and then it's going to be broken down by procedure: incision, excision, introduction. Your knowledge of the respiratory terminology is important. And it just says here about figure 16.1, and this is 16.1 in your textbook. I just copied and pasted it. As you assign codes from the respiratory subsection, just knowing your terms is going to be important. So it's broken down by anatomic site, then procedure. So a big part of the respiratory system is going to be endoscopies. So during an endoscopy procedure, a scope is placed through an existing body orifice or opening, or a small incision is made in a cavity for the scope placement. So we've heard of people having to have scopes to look for polyps in their stomach or something like that, and they'll either go through the nose, or most of the time they go through the mouth and down to the stomach. When they have a colonoscopy, they go through the rear with the scope and look at everything. Those are type of scopies. When sinus endoscopies are performed, a scope is placed through the nose into the nasal cavity. The codes for sinus endoscopy are 31231 through 31294. Y'all, these numbers get me sometimes. I get all dyslexic. So whenever you get something wrong because you transverse numbers on your test or something, I never mark it wrong because I know what you mean. I transpose numbers all the time. So multiple procedures may be performed within different sinuses. So here's some different parts of the sinus: the frontal, the maxillary, and the ethmoid sinuses. During the same operative session, the CPT manual has combined into a single code some multiple sinus procedures commonly performed at the same operative session. How are you going to know if it can be coded together? Well, it's going to tell you in your CPT. We're going to do some examples, so you guys don't worry. Okay, so we need to really be cautious about something. We need to code to the full extent of the procedure. So I'm going to read this and we're going to talk about it. Endoscopic procedures may start at one site, such as the nose, and follow through to another site, like the larynx or the bronchial tubes. It is important to choose the code that most appropriately reflects the furthest extent of the procedure. Okay, so let's talk a little bit about that. Hi, Jenny, welcome.
Hello.
So if it starts at the nose and say it goes all the way to the bronchos, let's say you need a lungs, but you only code to the larynx. You're missing payment from here down. You're not getting paid for everything that you've done. So that's why it's important to make sure, you know, how far, you know, you code to the furthest place that you've gone. I mean, if it goes all the way to your tummy, you're going to code all the way to your tummy, right? You're not going to stop at the chest. So we're just paying attention to how far the scopes are going. All right, let's talk about approaches for procedures. Hi, Chase. So here's some different approaches for surgery. There's open surgery. And open surgery is one in which the patient is cut open. Pretty self-explanatory, right? So an open surgery is when
should be.
So an endoscopic surgery is a surgical technique that involves the use of an endoscope, a special viewing instrument that allows a surgeon to see images of the body internal structures through a very small incision. Now, remember we talked about you can do an endoscopy two different ways. You can do it in an orifice, an opening already that you have, or you can make an incision and go in through the incision. Endoscopic surgery has been used for decades in a number of different procedures, including gallbladder removal, tubal ligation, and knee surgery. I had a gastric sleeve done. It was done laparoscopically. So I have these little bitty tiny things all around, and they stick these. I looked like an alien with all this stuff coming out of me. I looked like I had been abducted and they were doing experiments, because it really does look that weird, because they put the scope in one way and then they put the tool to take things out another way, and then they have something else to guide somewhere else. So, and that's less invasive. I don't know if you guys, some of you are not as old as I am, but I mean, I can remember like my grandmother going in to have a minor surgery, and they just would cut you open, you know, from, you know, here to there. Now they can just do little bitty incisions and you don't have that much recovery time. Where in the olden days, they really cut you open. It was really dangerous. The medical field has come so far. All right, so now we're going to do a coding scenario together. This is exercise 16.1 in your textbook. So it says, using the CPT manual, complete the following. So we need the CPT code for an endoscopic maxillary antrostomy. So do we want to talk about what we're going to look for? Well, I'm not going to do that because look, I've already taken pictures and done it. Because we have some new students without manuals. So you're going to look under maxillary sinus is where we're going in our CPT in the index. How do we know that maxillary is a sinus? Well, this is your maxillary, your head. So, and then once you go to maxillary sinus, right underneath you see antrostomy, and it gives us a code range of 31256. And this is in my way, so I can't tell you the other part. But if we go to our CPT, in the tabular, we're going to see 31256, nasal sinus endoscopy, surgical with maxillary antrostomy. So it lines up perfectly, right? Now, you guys remember, I'm still doing this for you guys because I have students on every different level, okay? So we're going to get to the part where we're going to do them by ourselves, but I like to do a couple that we're kind of going through them together. So the next one is a biopsy of an intranasal lesion. So how would we look that up? Well, it's a biopsy. So we're going to go biopsy, nose, and then intranasal. So it's 30100. Now, do we just stop there in the index or do we always check the tabular? We code two ways.
Always check.
Code two ways, right? So we found it in our index. Now we're going to go to our tabular and check to make sure that we have the correct code. It's correct. I've already checked it. Just telling y'all. Okay. And the next is a unilateral total lung lavage following smoke inhalation. So what we're going to look up, our key term is going to be lavage, which is here. Then we go look for lung, and then that word total 32997. Okay, I did not take a picture of it in the tabular, but you guys know we always look in our index, then we check the codes in our tabular to make sure we've chosen correctly. So that's basically exercise 16-1 done for you guys. I'm not sure. Let's see if that's what you guys. Oh, no, that was yesterday's assignment. So do you guys recognize it? Okay, so we're going to talk about some modifiers. Now, I have to tell you, I'm not going to name names or point fingers, but I have had some interesting modifiers on exams. I don't mark it wrong for modifiers simply because that's something that you have to get on the job training for, and I firmly believe that. But let's talk about what are some important modifiers for chapter 16. One is going to be modifier 50, which is bilateral. So what does bilateral mean? Both sides, right?
Both right sides.
Now, if your CPT code, when you check it in your tabular, it says unilateral or a bilateral, then you don't need that modifier. It's only when it's not indicating that you need the modifier. So let's see, modifier 50, bilateral, is assigned when polyps are removed from both the left and the right side of the nose. So that's an example right there of when you would use 50. So a modifier 51 means multiple procedures, okay? So a multiple endoscopic procedure may be performed through the same scope during the operative session. When this occurs, each procedure should be reported with modifier 51. I don't think that I gave any examples of modifier 51 on the exam because we just didn't have any. But if you're coding for a major procedure, you may have to do this. But again, that's something you guys will learn if this is your specialty, if respiratory is your specialty. Something that I wanted to point out is in your textbook, you guys have something called coding shots. Have you paid attention to them? Please pay attention to your coding shots in your textbook. The information there can be very, very useful. All right, are we ready to code? I want everybody to take a deep breath. And let's not freak out because some of them are long, okay? When you see all the words on the scenario, do some of you get nervous whenever there's a lot of words? I don't want you to. Most of what's on there we can't use. So, but we're gonna practice. So this is our first one. The preoperative diagnosis. Are we coding for a diagnosis here? No. So that's not something we need to worry about. I'm not asking for any diagnosis codes on the exam. The postoperative diagnosis is the same, but we're not looking for that. What is our actual procedure? I got to find my notes. Hang on a minute. I've already coded these and I want my notes. Right here. So, okay, so it's the placement of an anterior chest tube. I am going to say you need to skim the information. So let's skim it. What do I mean by skimming it? The patient was draped and prepped in a usual manner. Okay, that's fine. I don't need to know what the anesthesia was because what? We're not coding anesthesia, right? We're coding a procedure. Middle line, the anterior chest, and a 20F chest tube was passed. The chest tube was anchored using something sealed. The area was dressed. The chest tube was placed on. This is going to be important. Suction. The patient tolerated procedure well. See how little I needed in this scenario? I kind of just skimmed through it and kind of read it until I found something that was directly related to what was going on with the actual chest tube. What's it doing? It's what? It's suctioning. Okay. So as you get more experience, you guys, when as a cardiology coder, I could skim a whole medical record and my eyes were trained to only hit the words that I needed for that procedure. It's not going to take long to get to that spot. So what are we needing to do? We just my cat's going to help us code. Sorry. Shoo. So we just learned that it's formatted by anatomic site, then by procedure. So what would be our anatomic site in placement of an anterior chest tube?
Anterior chest.
Okay, let's break it down to just chest.
Mm-hmm.
So let's go to chest. Y'all know it's crazy. I do these ahead of time and I never write down the page numbers. I don't know why I don't write down the page numbers. Okay, chest is on 1064. Let me know when you get there.
Got it.
Okay, so if we go down until we see what? Chest, and then what is it that we have in our chest? We have a tube, correct? So when you look at tube, it says C, thoracoscopy. So what are we going to do? We're going to go to the thoracoscopy. Please pay attention to your terms and how they're spelled because it gets tricky.
Ectomy.
So I have 1,240. I did write it down on that one. So 1,240. So we're looking for an otomy, not an oscopy. Hi, Janisha, welcome.
Hi.
Okay, so on 1,240, are y'all there? Where did Melinda go? We lost Melinda. Okay, so if you look under thoracoscopy, you see drainage. Do we need drainage? No.
No.
The next one I can't pronounce. Then there's hemothorax, and then we have tube. Beside tube, it says 32551. Do you see that, Jenny?
Mm-hmm.
Okay. So let's take a look at 32551 in our tabular.
It's on page 234.
Yeah, I'll get some more water.
Y'all are just too fast. 32551 on page 234. Tube, thoracostomy, included connection to drainage system. So when it's on suction, what is it actually doing? It's sucking it out, and is it putting it back in, or is it draining it? It's draining it, correct?
Trainer.
Okay, so I believe that's right. What do you guys think?
Yeah.
Yeah.
So the answer is going to be 32551. All right, let's do the next one. Again, pretty big, right? Doesn't look as big here as it does on your test because I have it spread out long ways. But this is an inpatient operative report, indication, cardiogenic shock, and the need to initiate mechanical ventilation. What was our actual procedure? Intubation. All right. So here it talks about consent. We don't need that to code, right? And then it's endotracheal intubation. That would be important to know what kind of intubation. And again, endotracheal tube was used. And again, the cuff was, and all of this is just describing what they've done, but actually it was intubation. So what do you guys think that we're going to look up as our main term?
Intubation.
Intubation. I'm going to look under endotracheal, and I'm just going to see if if something is there, because I went to intubation earlier. I just want to see if it'll lead us there with the other word too.
Well, under intubation, we have the 2-31500.
Okay. Jenny, let us know when you're there, and to see if you agree with Janisha.
Okay.
1148, the page.
Yeah, I went to intubation. It says endotracheal tube.
Mm-hmm.
Right.
Did Janisa, did you check in the tabular to make sure it was right?
No, not yet. I'm gonna do that now.
Okay, while you're doing that, I'm looking up endotracheal. And believe it or not, if you do endotracheal tube, it says emergency intubation, and it gives me 31500. So you can go either way in this scenario. There's more than one way to skin a cat. And sometimes there's more than one way to code.
Yeah. On 224.
Do you agree that that describes intubation?
Yeah.
Yeah.
Okay, then I'm not going all the way back there. So it is 31500. All right, again, lots of words. Guess how many we need? Just a few, right? So our actual procedure is a bronchoscopy procedure. Okay, let's kind of look around. Procedure medications, again, this is all the doggone anesthesia applied with cocaine mixed along with lidocaine, into the throat. He was lying in a supine position, and then they were doing video monitoring. The bronchoscope was introduced through the nose and into the upper airway. The vocal cords were visualized. There were no endobronchial lesions noted. The vocal cords were moving equally with phonetation and respiration. The bronchoscope was introduced through the vocal cords and negotiated into the trachea. And all the way through here, and were visualized. No endotracheal lesions were noted. The right main, middle, lower, upper lobe bronchi. Boy, they just went all over the place, didn't they? They checked out everything. He did not have any significant cough during the procedure. So what did we actually do? We did a bronchoscopy. So we're going to look up bronchoscopy, right? Now, I want you guys to keep an open mind and know that not every time is it going to say exactly what we did. We're going to have to go outside of the box a little bit. So when we start looking at bronchoscopy on page 1056, I want to call your attention to exploration. Do you guys see exploration?
Yes.
Yeah.
Okay, so does it say anywhere in here that it was an exploration? It didn't,
No.
but because they went through all of these areas very, very meticulously, they were exploring to find out if he had lesions. So that's where we have to be a little bit broad-minded. That's where we have to put this word exploration into that toolbox in our brain. So whenever we see something, a medical record that looks like this, where they've gone all over the place, they didn't see anything, so they didn't do any sort of a biopsy, right? So we don't have to worry about that. There was nothing remarkable. Everything looked good. They just explored it. So we're going to start with CPT code 31622. So let's go and see what 31622 says. On page 227. Okay, so are we all on 227?
Yeah.
So we are starting with CPT code 31622. Bronchioscopy, rigid or flexible, including fluoroscopic guidance when performed diagnostic with cell washing when performed separate procedure. Now, does that exactly line up with the exploration? It really doesn't, does it? But this is what we need to do. Let's look at 31623. It says with brushing and protected brushings. We certainly didn't see anything about brushing anything, did we? All right, so let's continue to read on. 31624. With bronchial alveolar lavage. We didn't see anything about a lavage, so we know that that can't be it. With bronchial and endotracheal biopsies. Did we have a biopsy here? So that definitely can't be it. 26, with placement of fiticule markers, single or multiple. Again, that was not something that they did. And then 31627 can't possibly be it, because what is it? Has a
An add-on
plus.
code.
It's an add-on code, so we can't use that. So let's go ahead and look at 28. With transbronchial lung biopsy. Okay, so now we've gone too far, because now we're going into the lungs, right?
Right.
What's our only choice? 31622. In that section, that's really our only choice. So that's when you have to trust the index and say that that's what they mean would be the exploration. And we could probably do some Google and research on this particular code and get a lot more answers. But for the sake of you guys not sitting here researching, we're just going to make sure that you know that that is 31622. I'm kind of looking up at the notes above, and I don't see anything special about it. But that is our very first bronchioscopy code. Everything else just goes. I mean, I'm sorry, I'm looking on page 229, and what I'm seeing is all of these things are definitely not it. Like there's a removal of a foreign body, there's stents, excision of a tumor. So this is where we need to be on 227, and it's 31622. Does that make a little bit of sense? I know it doesn't exactly line up. We have to be broad-minded about it, because definitely anything else does not fit. All right, our next one. The physician views the trachea using a bronchoscope placed through an established tracheostomy. The physician examines the conducting airways. The bronchoscope is removed. Okay. So I have here on my notes, let's turn to page. Okay, we're already on page 227. Let's look at the red lettering section. It says trachea and bronchi. Do y'all see that?
Yes.
So this is incision. A tracheostomy. We're not doing a tracheostomy. A tracheostomy already exists, right? Okay, so that's not an incision. So let's look at the endoscopy. And this is where exactly where we were before. We were looking at 31622 is where we were looking. So because we're still here, I want us to look right here. So endoscopy, and then we have 31615. What does that say? Tracheobronchoscopy through established tracheostomy incision. So does that match what we're looking for?
Yes.
Yeah.
I didn't think that we needed to go to the index. I wanted you guys to know that if you kind of recognize, remember we talk about getting to know our CPT. If you put a tab that says tracheostomy right here, whenever you get ready to do something that's trach related, you can just turn right to it. So, but anyway, so we were in the same section. All right, this is going to be our last one, and it's going to be easy. So we did an excision of a nasal polyp. So what did we do?
Excision.
We excised something. So we go to excision. And our nasal is our nose, right?
Voucher was
30110 to 30115.
Yep, that's the code range I got too. I'm lazy on this one. I've got the answer already. I'm letting y'all I'm letting y'all do the hard work on this one.
30110
Does everybody agree?
219.
30110. That one was pretty simple compared to the other ones, right?
Yeah.
But I don't think any of these were real hard. So every single one of these scenarios that we just went over will be on your exam. And I made sure to go over the hard ones, right? The ones that are long. Hi, Miss Wanda.
Hi, Miss Marsha.
Y'all, Miss Wanda's last day is tomorrow.
Congrats, Miss
Congrats.
Wanda.
Thank you.